So Ted, how many patients do you suppose in general primary practice offices have an unrecognized issue with opiates that ought to be addressed?
Well, it's interesting, Jeff. At least 80% of the primary care patient population don't have a problem with a substance use disorder, so 80% or so. Of the 20% that do have a substance use disorder in primary care, those people are actually overrepresented in a chronic pain population. And so if you're thinking about the specific primary care population with chronic pain, more than 20%, possibly as much as 40%.
Is that right?
Will get in trouble with opiates.
And how do we pick that up? How do we find those 40%, as many as 40% of patients who have a problem?
Yeah. Well, first of all, we tend to miss them. And then we find out in retrospect, and those are the patients who we wish we had never prescribed to, but don't really know how to stop prescribing. So I think we do need to do a better job of looking for them. There are some indicators. The first is sort of a general screening approach, using a standardized screening tool like maybe the Audit-C. The Audit-C screens for alcohol problems. And since the majority of people who have drug problems also have alcohol problems, if you can find people with an alcohol problem, that's a good screening tool. Any patient with a history of a substance use disorder, should be considered a high-risk patient. Patients who pressure the prescriber-patient relationship, seem to always want more medicine, and you all seem to always want to give them less medicine. People who trigger positive on a tox screen for either unreported recreational drug use or ongoing use of prescribed drugs from some other provider. People who show up on a pharmacy monitoring profile as multi-sourcing or getting substances from other docs. Those are the ways to look for people who have these sort of high-risk brains, people with substance use disorders who are likely to get in trouble with opiates.
Is one of those predictors the affect that those patients bring to the interaction, that they tend to bring a lot of urgency or their own sense of distress? Does that characterize those folks often?
Yeah. When a person acts around their opiate prescription as if it's a blood pressure pill, that's sort of a low level of affect. When a person begins to act around their opiate prescription as if they have a living, breathing love relationship with the thing, some urgency, early refills, a lot of referential talk about the opiate prescription, like my pain medicines, as opposed to those cholesterol pills, that's kind of thing.
Almost as though it's an entitlement.
Almost as if it's an entitlement or as I said, a living, breathing, significant other relationship.
So what about the patient who feels as though they have a remote substance use problem, that long ago they had a problem with a substance, but feels as though they've put it behind them, or the provider who thinks that this is so remote that it's really not a consideration any longer? How do you handle that one?
That can be a real pitfall. It's actually important to conceive of substance use disorders as a lifetime diagnosis, a diagnosis that a person carries forward. It can be in remission, but it's still in their brain. A brain that lost control of its use of alcohol or other drugs in the past is highly likely to lose control of alcohol or other drugs in the future if given longitudinal access, long-term prescribing. I kind of use the analogy of if you knew a friend or a family member or a patient who was 12 or 15 years sober from alcohol, and they invited you to one of their anniversary AA meetings, you'd never consider congratulating them with a six-pack of beer or a bottle of wine. That's a lifetime diagnosis.
So what you're saying is that really someone with that history should never be treated with an opiate.
They should never be treated with a longitudinal controlled drug prescription, opiate or any other. But if they had cardiovascular surgery and had their sternum cracked, or they had a short-term reason to need a brief course of a controlled drug that can be less dangerous. But still, we tend to bend over backwards to try to find alternatives.
So you're making the distinction between acute and chronic pain.
Yes, a person with an acute pain syndrome who has a history of a substance use disorder may well get a very short course of an opioid. A person with a history of opioid addiction who has an acute pain syndrome, with those people, I even try to avoid opioids altogether, even for a short course.
So once you've decided that opiates are high risk, what are the steps you ought to take as a provider?
When I've decided that opiates are high risk, I think it's essential to help the patient understand that and realize that that the ethical principle involved in the doctor-patient relationship from a hierarchical standpoint is first do no harm and then comfort. And so if I keep that in mind, I can let the patient know that it's potentially endangering their health and safety if I provide them opioids on a long-term basis. And as a consequence, avoiding opiates is critical. Now, if the patient is on opiates, our options are relatively limited. Patient with a substance use problem who's on opiates, I'm really not allowed, and I don't think any of us are really allowed ethically to pretend that we don't know there's a substance use problem. That's a disaster. So the options are to taper off of the opiate, to refer for medical withdrawal or detox, to switch to buprenorphine, or to refer to a methadone clinic.
And if those approaches are put into place and the patient still complains of pain, how do you handle that?
Well, that's when it's important to introduce to patients the concept of opiate responsive pain and opiate non-responsive pain. For example, if I have a person with a substance use problem, they've gotten in trouble with opiate prescriptions in the past, I've switched them to buprenorphine as their only opioid to treat their substance use addiction issue as well as pain, and they say, but I still have pain. I point out to them that the part of the pain, the fraction of their pain that can respond to opioids has responded to the buprenorphine. And what's left over is pain that doesn't respond to opioids, and therefore we need a biobehavioral model to approach what's left over.
Excellent. I like that way of thinking.
Yeah.
So summarize for us, if you would, just what we've learned today.
Well, there are a substantial minority of patients in primary care practice who are high risk if exposed to opioids, especially exposed to them long term. It's important to screen for those people, to screen for the behaviors that trigger our concern, or screen for a history of a substance use disorder. Once you've found a person who's one of these high-risk patients, it's just not ethical to continue to prescribe opioids and pretend like we don't know. We need to switch to one of the alternatives: tapering off, medically withdrawing off or detox, buprenorphine, or methadone. And then finally, the patient who is on, say, buprenorphine or methadone and still continues to complain of pain, it's essential to introduce the concept of opiate responsive pain that's already responded, and that's as good as they can get from opiates. And what's left over is the pain that we need to use a biobehavioral model to address.
That's such a helpful kind of outline of the ways we need to really handle this potentially difficult part of the pain and substance use population. Thanks so much, Ted.
You're very welcome.